I want you to picture a specific moment. You've just bought your first pair of scrubs.
Okay.
You're standing in front of the mirror in your bedroom. You've got the stethoscope. Maybe you're trying to figure out, if it looks better around your neck or in the packet. You catch your own reflection, and you feel this wave of pride right you mid into nursing school.
Yeah.
But then, right behind that pride, there's this cold, sinking feeling of just absolute terror.
The imposter syndrome moment.
Totally.
Yeah.
You realize you're about to walk into a hospital, not as a visitor, not as a patient, but as someone who is supposed to know what they're doing.
Right.
And suddenly it feels like everyone else has the script, they know the blocking, they know the lines, and you are the only one improvising.
That is such a universal experience for nursing students. But here's the thing. That feeling, it isn't just nerves. It's not just first day of school jitters.
Oh.
It is actually a textbook definition of culture shock.
See, that is the concept that grabbed me. We usually talk about culture shock when you travel to, say, Japan or Brazil.
Right.
But today we're talking about the hospital itself as a foreign country.
Exactly. The premise we're diving into today is that healthcare isn't just a workplace. It's a distinct culture. It has its own language, its own rituals, its own hierarchy, and, its own values. And if you're a nursing student listening to this, you are currently going through a process called acculturation.
Which is basically the process of learning how to become a member of the tribe.
Right. But here's the danger, and this is why we're doing this deep dive. The better you get at being a member of the tribe, the more native you become to the healthcare culture.
The bigger the wall you build.
The bigger the wall you build between you and the very people you're trying to help, your patients.
That's the paradox. To do the job, you have to join the culture. But joining the culture, it separates you from the human beings you're treating. So today isn't just about definitions. It's about how to recognize that wall and hopefully how to put a door in it.
I love that. Let's start with the basics. When we say culture, most people think of, food, holidays, maybe music. But sociologically, culture is about shared values, rules, and artifacts.
Artifacts, that sounds like archaeology. But in a hospital, we're talking about physical symbols that say, I belong here.
Precisely. The most obvious one is the uniform, scrubs.
The white coat.
The white coat. The stethoscope. These aren't just tools, they're badges of authority. I mean, think about how a patient reacts when someone in a white coat walks into the room versus someone in street clothes.
The energy changes immediately. The patient sits up straighter. They stop looking at their phone.
That is the power of the artifact, and it goes beyond clothes. Think about the environment. If you walk into an MRI lab or an operating suite, what do you see?
Stainless steel, bright lights, machines that make these loud, rhythmic noises. It's cold.
And to an outsider, it is terrifying. It looks like a spaceship.
Yeah.
But to you, the nurse, that's your office. That's where you drink your coffee. That desensitization is step one of acculturation. You stop seeing the environment as alien, and you start seeing it as home.
There's also the ritual aspect. A lot of nursing and medical schools actually have a white coat ceremony now.
They do.
I always thought that was just for the parents to get a nice photo for Facebook.
Well, it is a lot deeper than a photo op. It's a rite of passage. Anthropologically, it's no different than a knighting ceremony or a tribal initiation.
Huh.
It's the institution saying, welcome, you are one of us now. And once you go through that ritual, the expectation is that you've crossed a line. You are no longer a lay person. You're a provider.
And with that title comes the biggest barrier of all, the language.
The jargon. Oh, man.
It's intense. Healthcare is one of the only professions where you basically have to learn a completely new vocabulary just to get through the day.
Law, maybe.
Law might be the only other one that comes close.
It is a second language.
Yeah.
And you have to learn it to survive. You can't say tummy ache to a surgeon. You have to say abdominal distension or appendicitis.
Right. You can't say sadness. You talk about depressive affect.
Yep.
But wait, let me play devil's advocate here. Isn't that precision necessary?
Yeah.
If I'm the patient, I don't want my nurse using vague, fuzzy words. I want them to know exactly what's wrong.
Right.
Don't we need that separate language for safety?
We absolutely do. Within the tribe, between the nurse and the doctor, or the nurse and the pharmacist, that shorthand is vital. It's fast and it's precise. The problem isn't that the language exists.
Okay.
The problem is what happens when you turn around and use that same language with the patient.
Right, because they don't have the dictionary.
Exactly. To the tribe, heart failure is a specific diagnosis describing the pump function of the heart. To a patient, hearing the words heart and failure together sounds like.
You're about to die right now.
Exactly. Or when you hear positive nodes, in normal life, positive is good.
Yeah.
In the hospital, positive is very, very bad.
Precisely. So you have this linguistic barrier, but it gets even more complex. We've been talking about the healthcare culture as one big happy family. But anyone who has spent 5 minutes on a hospital floor knows that is not true.
Oh, definitely not. There are tribes within the tribe.
We call these co-cultures.
Yes, co-cultures. You have the nursing co-culture, the medical or doctor co-culture, the administrator co-culture, and they don't just wear different badges. They actually view the world through different philosophical lenses.
And the material we looked at highlights a specific clash, right, between the nursing model and the medical model.
It does.
And I think for a student, understanding this explains so much of the tension they might feel during clinicals.
It explains a lot. Generally speaking, nursing education is built on a biopsychosocial model.
Okay, let's break that down because that is a mouthful. Biopsychosocial.
It means you are trained to look at the whole human, the biology, the disease, the psychology, their mind and emotions, and the social. Their home life, money, family.
That's holistic.
It's holistic.
Yeah.
And the medical model?
More focused.
Traditionally, medical school and PA programs have been biomedical-centric. The primary focus is on the pathology, the broken bone, the infection, the tumor. The goal is to fix the biological problem.
So let's imagine a scenario. You have an elderly patient, Mrs. Jones. She has a hip fracture.
Right. The biomedical perspective, the surgeon comes in and says, great news, the surgery was a success. The hardware is in place, the bone is set. Discharge her tomorrow.
Job done.
From their cultural perspective, the job is done. Success.
But the nurse is standing there thinking, wait a minute. Mrs. Jones lives in a third-floor walk-up with no elevator, she lives alone, and she can't drive.
Exactly. That is the biopsychosocial view. The nurse realizes that biologically she's fixed, but socially, sending her home is a disaster waiting to happen.
And that is where the conflict starts. The nurse is fighting for more time or a rehab placement, and the doctor's looking at the chart saying, but she's medically stable.
That is intercultural conflict. It's not that one person is bad and the other is good. It's just that they prioritize different values based on their training.
I feel like that is shifting a bit, though. We hear team-based care all the time now.
It is shifting. The old captain of the ship model, where the doctor gives orders and everyone salutes, is fading. Slowly. But those cultural roots run deep. Friction is still the reality in most hospitals.
So we have the tribes fighting amongst themselves, but let's flip the camera angle. Let's look at the person lying in the bed.
The patient.
If the hospital is a foreign country and the staff are the government officials arguing over policy, who is the patient?
The patient is an unwilling tourist. A tourist who didn't pack a bag, doesn't speak the language, and was possibly kidnapped and dropped there against their will.
That is a terrifying image.
Yeah.
But it fits. They don't know the customs. They don't know the rules.
I mean, think about how vulnerable that feels. When you travel to a country where you don't know the norms, you feel insecure. You don't know who to trust. You misinterpret gestures.
And in the hospital, normal behavior by staff can seem totally bizarre to a patient.
Take emotional restraint. As a nurse, you are taught to be professional. If a patient is crashing, you don't scream and cry.
No.
You get calm. You get efficient.
You put on your game face.
Right. But to the patient's family who are panicking, your calmness can look like coldness. They think, why aren't they upset? Don't they care?
They're reading it through a different set of rules.
They are reading the situation through normal social rules, not hospital culture rules.
There's also this huge piece about identity. This part really struck me. When you become a patient, you lose your identity.
You are stripped of it, literally. You take off your clothes, your style, your signifiers, and you put on a gown that is open in the back.
Yeah.
You are essentially infantilized.
You go from being independent to having to ask permission to go to the bathroom.
Exactly. And the research on this, specifically from a sociologist named Sharmaz, identifies 4 ways patients react to this identity crisis.
Oh, okay.
And I think for a nursing student, recognizing which one your patient is experiencing is a superpower.
Let's run through them. The first one is the supernormal identity.
This is the denial phase. Picture the businessman who has had a mild heart attack. He's in the bed, but he has his laptop open. He's taking conference calls.
I don't have time for this guy.
Yes, and he's telling the nurse, I'll be out of here by 2:00 p.m. He is clinging to his pre-sickness identity.
Then there is the restored identity.
This is the optimist. They admit they're sick now, but they are convinced they'll bounce back to 100%. They're the ones who say, I'm going to beat this and run a marathon next year, even if the diagnosis says otherwise.
They haven't accepted the new normal.
Not yet. Then reality sets in. The contingent personal identity.
This is the turning point.
It is. The patient starts saying, I can do this contingent upon my energy, or I can go to the wedding if I have my medication. They're starting to negotiate with the illness.
And the final one, which I guess is the goal, is the salvage self.
Yes, the salvage self. This is acceptance. It's not giving up, but it's integrating the new reality. I am a stroke survivor, and I walk with a cane, but I am still a grandfather and a writer.
They've rebuilt their identity.
They've rebuilt their identity around the limitations.
That is so helpful, because if you have a patient who is acting difficult, maybe they're just stuck in the supernormal phase.
Exactly.
They aren't fighting you. They're fighting the identity of being a patient.
Precisely. Empathy comes from understanding that struggle. But we have to address one more massive wall between the nurse and the patient.
Okay.
And it isn't psychological. It is economic.
The invisible wall of money.
In the U.S. healthcare system, money, or the lack of it, dictates the entire experience. We have a tiered system. We just have to be honest about that.
We do. You have the concierge tier.
Yeah.
At the top, wealthy, cash-paying, immediate access.
Yep.
Then the middle tier with private insurance. And then the government tier with Medicare and Medicaid.
And at the bottom, you have over 30 million uninsured Americans. And this creates a specific culture clash in the emergency department.
Oh, yeah. The ED is where the friction is the hottest.
It is, because legally, the ED is the only place that must treat you regardless of ability to pay. So if you're in that bottom tier, the ED is your doctor's office.
You go there for a toothache, a sore throat, a refill on meds.
And meanwhile, the ED staff who are trained to treat gunshot wounds and cardiac arrests, they're frustrated. They see it as misuse of the system.
And the patient sees it as survival.
So you have this collision. The patient waits 6 hours for a minor issue, getting angrier and angrier. The staff gets cynical. It's a structural setup for conflict.
There is also a huge disconnect on medication costs. The sources pointed out that most providers, doctors, and nurses actually have no idea what the drugs they prescribe cost.
It is a blind spot. A provider prescribes Zithromax or Crestor because it's the best drug clinically. They hand the script to the patient.
And that's it.
The patient goes to the pharmacy, finds out the copay is $150, and they just walk away.
They don't fill it.
They don't fill it. They are too embarrassed to tell the doctor they can't afford it. So they go home, they don't get better, and they end up back in the hospital.
And the provider labels them non-compliant.
Exactly. This patient doesn't care about their health. When in reality, the patient is choosing between rent and medicine.
That socioeconomic gap. It just makes it incredibly hard for a patient to trust a provider who seems to live in a different economic universe.
It does.
Okay, we have painted a pretty intense picture. We have language barriers, identity crises, tribal warfare between doctors and nurses, and a massive economic divide.
Yeah.
If I'm a nursing student, I might be feeling a little overwhelmed right now.
Don't be.
Yeah.
Because realizing all of this, that is the solution.
Let's pivot to bridging the gap. How do we tear down these walls?
It starts with language. You have to become a translator. When you speak to a colleague, use the jargon. Be precise. But when you turn to the patient, you have to switch codes.
High blood pressure instead of hypertension. Walk instead of ambulate.
And check for understanding. There's a technique called teach back. It is the gold standard.
How does that work?
Well, usually we ask, do you understand? And the patient just nods because they don't want to look stupid.
Yeah, everyone nods.
Instead, you say, I want to make sure I explain this clearly. Can you tell me in your own words how you're going to take this medicine when you get home?
Oh, that's good. That puts the burden on you, the explainer, not them. It's clever.
It forces them to process the information. If they can't explain it back, you know you haven't bridged the gap yet.
What about the identity stuff? How do we help the tourist?
Be a guide. Orient them. Explain who people are. I am your nurse. I will be here for 12 hours. That person in the blue coat is a phlebotomist. They just draw blood.
Reduce the mystery.
Exactly. And the money. We can't pay their bills. No, but we can stop shaming them. We can have empathy regarding cost. If you prescribe a medication, ask, will you be able to pick this up? If the answer is no, help them.
Connect them with a social worker or look for generic alternatives.
Exactly. Don't just be a clinician, be an advocate. That is what the biopsychosocial model is actually about.
So let's bring this all home. We start with that student looking in the mirror, feeling the terror. of the new scrubs.
And we established that you are entering a powerful, exclusive tribe. You are gaining citizenship in the land of healthcare.
You have the artifacts. The white coat gives you status. The language gives you authority.
But the core message of this deep dive is this. You can use that citizenship in two ways.
You can use it to separate yourself, to stand above the patient, hiding behind your jargon and your busy schedule, acting like the annoyed local dealing with a confused tourist.
Or you can use your citizenship to be a bridge. You can remember that you chose this culture, but your patient was forced into it.
You can be the translator. You can be the guide who makes the foreign country feel a little less scary.
And honestly, when you're at the bedside, holding someone's hand at 3 in the morning, that connection is worth way more than the fancy title or the white coat.
That is the thought to take into your next shift. Are you a gatekeeper or are you a guide?
Thanks for listening to this deep dive. Good luck with your clinicals.
See you next time.